Well, good evening, everyone. Most everyone knows who I am, but for Kevin's sake, I'll introduce myself again. My name is Mike Snells. Michael worked just fine. We do have two guests today from Family Resource Center to talk to us a little bit about that youth picture. Judge Johnson talked about some of the justice system and how she can help guide youth that get into trouble. And so this will fit quite nicely on some of the social issues that the community is involved with. So, you remember how this works? We're missing only one student right now, but I'm sure Abby will come in soon enough. And so we don't really need to worry about the role. The typical presentation is, of course, the questions that you don't know anything about yet. We'll see what you already bring to the table. Then we'll invite our speakers to introduce themselves a little bit and then talk to us about some important issues, and then of course open it up for question and answer. We'll come back to those questions to see how much you've learned, and then we'll have a little bit more time to wind up at the end as well. So you guys know how this works, but for the benefit of others. So, continuation of what we did last semester. We're going to continue this course again next year. 2 different semesters, different set of presenters. Perhaps we can bring FRC back again next year. Sure. We will be contacting people in the summer probably to see their interest. This was what was in the material sent out to the community and to the students about what our aims were as far as engaging a dialogue and coming to a better understanding of all the many professions that have a piece of the solution in their hands. And hopefully we're encouraging, all the students are pharmacy students, except Will. He's got quite an interesting background, but he's our videographer, so that's all good. So here's what's on tap for the rest of the semester, Kevin. So if you want a copy of this.
I have one already.
Great. How'd you do that? That's nice.
Through a renewed mind.
Oh, nice. Very good. But anyhow, you can see where we're going the rest of the semester as well. All right, here we go. Clicker practice. See if you can make it work. Now, it's A or B. I dare you to push C. See what happens if you push letter C. You get a little amber light, don't you? Yeah. That tells you that that's not a choice. The computer is set up to take your last entry, so you can change your mind at the last second until I advance the screen, and then it captures whatever you put in. So, this was a question from last week. We'll see how much you guys remember. And if you don't score well enough, I will call the judge myself and tell her to come back and put you all in front. So I'm up to, better get my old man eyes. Ooh, check that out. Very good. Wow, you guys are awesome. What was the percentage of students?
9.
Yeah, 9%, 10%. Oh, yeah. Now you're in there. You're in there with the allowance, right? Statistical allowance. We're good. Wow. All right, 9% of them test positive on 9.9.
Yeah, around it.
And of course, I think most of us are thinking, they're derelicts. They're in the justice system. But her point was it often isn't really the drugs. There's some other stuff going on, and you guys know this better than we do. So now let's see what you know about the rest of the questions here. Socially and clinically, the most significant concern of the past century is the lowered age of onset of substance use. What do you think? True or false? True or false? All right, we're up to 9. That's what I would get. All right, we're pretty much like-minded. Now, whether that's correct or not remains to be seen, doesn't it? All right. There are no child and adolescent certified alcohol and other drug treatment providers in our community. True or false? No child and adolescent certified treatment providers. fine. All right, we are very like-minded. Students are good though. Whenever they see these grandiose statements, they pretty much know that that's always, never. They're pretty good at keying in on it. Now we'll see if you're right. No difference between how you treat children and adolescents compared to adults. True or false? Can I get 2 more votes? 50-50 chance. Yes. All right, we're very like-minded here as well. Obviously, we are thinking that there is significant difference there. The only proven method to treat alcohol and other drug abuse is to enter a rehabilitation facility. True or false? All right, most of us disagree with that statement. I'm sure we'll learn a little bit more about what goes into that. Hancock County has embraced a recovery-oriented system of care. True or false? Recovery-oriented. All right, there's a little bit of difference of opinion, so let me explore how some of us can have a slightly different, well, not slightly different, 180-degree different opinion than the others. So, today we have Melissa Meyer, the Chief Clinical Officer, and Josh Ebling, the President and CEO of the Family Resource Center for Hancock County, so Northwest Ohio. So, I'm going to invite them to take the podium. I'll relinquish my clicker, and hopefully they can tell us just a little bit about how they got to this position, where their passions are, and what they think community members can contribute, especially pharmacist community members. You guys aren't pharmacists yet, but you can see it. Some of you can see it from here. So that's all good. So who gets the magic here? All right.
I should say ladies first.
No.
Okay, thanks for coming tonight, guys. Before I tell you a little bit about myself, and Melissa does the same, I want to know a little bit about you guys. So I might talk a bit about some of you are maybe a little closer than others. Give me an idea. Are everyone is a graduate student then? Is that what I'm assuming? No? Undergrad? First year?
You're not sure how to answer, Josh, because at Finley, you're an undergrad until your 4th year of our 06 program, and then all of a sudden you're elevated to graduate student.
Gotcha.
And you start over with your GPA as well, which
Okay.
is interesting.
So what's the best way to ask that question? First year student?
Yeah, P1 through P6, yeah.
Okay, all right, so how many people feel like they're at the beginning? The light at the end of the tunnel is way out there. And you guys are a little further down the track?
4 or 6.
4? All right. And you're from the community, is that what I heard?
Mhm.
Great, thanks for being here tonight. Appreciate that. I want to tell you a little bit, mostly about FRC. My background probably isn't as interesting to you. But I am a licensed independent social worker, which means I'm licensed to practice psychotherapy in the state of Ohio, and I've done that since, well, I've been in the field since about 1997. So going on, I take that back, 1996. So about 20 years. Predominantly work with, are you going to say that was the year you were born?
Yeah.
All right. I just got another gray hair. Thank you. Appreciate that. Predominantly work with kids. That became my area of expertise. One of the things we talk about a lot in our field is the fact that kids are not little adults. Hopefully you guys know that already, but we're going to talk a little bit about what that means developmentally. I've been a part of Family Resource Center for over 7 years. I want to talk to you a little bit about the agency. By the way, how many people have heard about FRC before seeing this on the schedule for this series? Anybody? Attaboy, Will. All right. I'm going to go ahead and click forward here. We are actually an agency that is rooted, this is from another slide that we present along with some of our other collaborative partners. By the way, is it okay that I stand here?
Wherever you want,
Okay.
yeah, Josh,
All
wherever
right.
you want.
We are rooted in Lima and Allen County. Hancock County here in Findlay is our largest satellite office. But we also have satellite offices in St. Mary's, down in Auglaize County, Kenton, over in Hardin County, Shelby County, the city of Sydney, down in Shelby County. We have satellite offices at Fostoria Schools, over in Seneca County, and also Van Wert City Schools, over in Van Wert County. We started out with the intent to help kids in 1985. We are certified to provide mental health services as well as alcohol and drug treatment services throughout all of our locations. Kids are our expertise. We do not dabble in adult work because we know where our expertise is, and that's where we stay. And any geographic expansion that we've experienced is really because folks have asked us. For instance, our most recent office in Shelby County, we opened about 3 years ago in juvenile court. Judge at that down there, Children's Services asked us to come down there and provide services because, as most of you probably gathered, I wrote the statistic down. I think it was 100% of you said, yeah, the age of onset for kids using alcohol, drugs is definitely getting lower. And I would broaden that to a larger kind of social issue or behavioral health issue, and that being kids are dealing with more adult issues at younger ages than we've seen in previous years. And because of that, lots of things come along with it. We are an agency of about 70 staff, all of those offices combined. We contract with schools directly, we contract with Adamus boards, and we contract with juvenile courts, children's services, other social agencies or collaboratives. We're also a third-party reimbursement provider, so if you have private insurance, just like going to visit your pediatrician, that's how a lot of our services are paid for. We also have grant funding, etc. We serve about 3,500 kids on an annual basis. We serve about another 10,000 more in prevention services. We'll talk a little bit more about what prevention services are here in a bit, at least in our world, in the world of mental health or behavioral health, which of course includes alcohol, drug treatment. Any questions about this so far? By the way, the certification I spoke of is from the State Department of Mental Health and Addiction Services. We are one of a few agencies in this region that are certified to provide alcohol and drug treatment and prevention services, specifically to kids. I think I heard Renewed Mind earlier. They are also another agency certified on the AOD side to work with kids. We're going to talk to you about a few things. I saw, I think, Precious' name, Precious Stubbe, will be with you in a few weeks to talk about ROSC, or Recovery Oriented System of Care. I'll give you a teaser because I certainly don't want to steal her thunder on that. But I want to talk to you a little bit, and actually I'll turn the mic over to Melissa to talk about our continuum of care. What does that mean, behavioral health services? It's sort of an all-encompassing term, and how does that fit with the alcohol drug scene, and therefore how does that relate to your chosen profession as pharmacists down the road? We'll talk about ASAM. Anybody know what the levels of care? Anybody know what ASAM stands for? I can't imagine you would. It's the Academy.
American Society
American
of Addiction Medicine.
Society of Addiction Medicine. They looked at as sort of guru with regard to assessment. Melissa will talk a little bit more about our stages of change as well. So that's it. It's a pretty basic presentation, and I'll turn it over to Melissa. Unfortunately, this probably isn't super easy to read, but I understand you guys can download this or read this electronically too. So hopefully it's good enough that you can follow through follow along with her as she talks.
We're going to be on this page for a little bit. I'm Melissa Meyer. I am the Chief Clinical Officer. I have my independent license in counseling. I've been with Family Resource Center for 16 years. So as I was saying earlier, I've kind of grown up in my mental health career with Family Resource Center. Since being with Family Resource Center, I've been therapist, supervisor, and now overseeing all of our clinical programs, both mental health and our drug and alcohol services. So I guess just to start off, we talked about the behavioral health piece, and that encompassing both kind of mental health treatment as well as alcohol and drug treatment. With the agency serving kids, it's really important to us as an agency to offer as many of the services on that full spectrum of need that kids and families may have. So as you see on this continuum, we go from the far end of the lower intensity services of prevention education programs to much higher intense services, both in the mental health area as well as the alcohol and drug treatment areas. So to start, I'm just going to start, if you look in the first column, prevention education services. A lot of our prevention education services, all for the most part, are provided within the schools. We have very evidence-based curriculum programs that really talk about mental health education, drug and alcohol education, prevention, really talk about how to avoid falling into the pressures of using substance use, and just explaining and educating kids on what mental health is, mental health issues could be, and how to deal with that and to address it. One of the particular programs in the prevention category, in the education category, we'll talk a little bit more about later, is the Challenge program. That is an education program that oftentimes we get kids referred to it when they've maybe been caught underage for underage drinking, or they are on a sports team and they've been caught drinking and they have to participate in some education program to allow them to get back on the team, or a judge may order that as kind of a diversion type of sentence if they get caught for underage consumption. So as we move up to higher levels of the treatment, we go to basically outpatient counseling. Outpatient counseling both for mental health and substance abuse. Come into the office, see the therapist, could be on a weekly or bi-weekly type of intensity, working on a treatment plan, working with the family. With our services, it's very family focused. That's why we have family in our name. We really believe when you're working with kids with any type of substance use issue or even a behavioral health, mental health issue, that family system is very, very important in making sure that the whole family participates. Obviously, we move on to different categories of treatment. We have a problematic sexual behavior treatment, which is just youth that have been maybe adjudicated, charged with, or maybe being investigated for some problematic sexual behavior. So it's a certified program that we work with to prevent any kind of ongoing issues with those behaviors for those youth. Intensive Home Base is a mental health program. That's intensive treatment. Therapist goes to the home with the families multiple times a week. Real intense treatment, crisis stabilization. And then we have our intensive outpatient program, which is another program we'll talk a little bit more about. That's drug and alcohol specific treatment for youth that are really falling on a deeper end of use or dependence with substances. So they need a more intense level of treatment versus just the outpatient level that's maybe once a week or bi-weekly. All of these are working through some kind of treatment plan. There's family involvement at every level. Even with the Challenge program and education, there's a portion of that where we bring the parent and the family in and talk about some of the pieces of the education, so the parents also are hearing the same information that the kids are.
Jump.
Anything you'd like to add?
Yeah, I'll just jump in quickly. We keep talking about these certifications. I want to talk a little bit about what that means. Of course, you know what it'll all be to become licensed or registered or certified for your craft. Likewise, programmatically for us, if we're not licensed or certified as a program, that means something. And what it means to be certified is that we not only meet minimum standards of care, but also that the programming we provide ongoing. You hear Melissa talk about evidence-based programming. Is that a term that you guys are familiar with? And so, good. So what it says is there's science behind it. There's research behind it. And if you offer the program to fidelity of the program, that which is known to work, and that is why it is evidence-based, if you maintain that fidelity, then you will get good clinical outcomes. And so it's important for us to reach that level of certification for various programs. For instance, the problematic sexual behavior program is actually licensed by the State Department of Youth Services. The IOP program, the IHBT, or Intensive Home-Based Treatment Program, those are licensed by our Department of Mental Health and Addiction Services. And written into state law are those fidelity measures that say how often are you going to see the child and or family per week? What are the elements of the programming that you will encompass? So those kinds of things are written into that, and that's why it's not just kind of tooting our own horn. We're certified. We're certified. It means something legally as well as clinically and therapeutically, and from an efficacy standpoint with clinical outcomes.
So on this continuum, the first thing, how do we determine where a child's going to fall as far as what service? And you can kind of see it at the top: consultation, assessment, screening, or referral. We're going to get a referral, maybe from juvenile court, maybe a self-referral, maybe from children's services, maybe from a school. And we're going to complete an assessment. And this assessment is, developmentally focused for their age, for adolescents and youth, comprehensive assessment. So we're asking, presenting problems, history of behavior, family history, developmental milestones, any kind of trauma events that they've been impacted by in their life. And then if we're targeting in and seeing, if there's any substance use, if a substance use has been identified, when, how often, frequency, what's the history of that? Is there family history of substance use? Mental health history, if they've had any instance of suicidality or homicidal tendencies. Is there family history of any kind of significant mental health diagnosis, treatment? All of that is gained at that assessment process. And then from that, we're going to make decisions based on where kids need to go as far as this continuum of care. Where do they fit at the appropriate level of care that they need? So just to talk about, if kids come to us maybe from a school because they got caught drinking at a party, that may be the only problem they've had. There's no mental health history. There's not a long history of use. We're probably going to put them in our challenge program, which is one of the prevention education programs on the lower intense level. They attend three sessions. The first 2 sessions are just with the kids. The last session is with parents included. And we're really educating them on the impacts of drinking and drug use, at what age, how it impacts the brain chemistry, how it can lead to a higher risk for long-term addiction. Give the same information to the family. They're going to work in different groups. Question, answer, have homework, come back with that. At the end of that, they do a screening, which is called the SASE. It's a substance use subtle screening tool, inventory. And really that's just going to score them on, do they have more of a significant substance use issue that maybe wasn't identified earlier? Do they need more ongoing treatment? Do we need to refer them to counseling on a more consistent level? Or is it something we just have to make sure we talk with the parents about? Supervision is an issue, etc. So, at that point, we're giving that education piece, that right dosage of education that they need based on their presenting issue at that time. Screening through it, making sure that there's not anything that we've missed, and if there is, we make that referral recommendation. And if not, then that piece of that treatment is over for that particular youth. And then, they move on. If at that assessment, we are seeing a kind of an indication of a stronger tendency or more use of substance use, we're gonna move on and do what we call, it's the ASAM, the levels of care inventory. So what we do with this, slow me down if I'm talking too fast. There are 6 dimensions on this assessment. In each one of these dimensions, and I'll show you a little bit more about how it's scored, you go through all of these different categories. The first dimension is the acute intoxication or withdrawal potential. If you have an adolescent that's coming to you that is potentially using significantly and regularly, what you're assessing for is their potential for withdrawal. Is their use significant enough that if they stop, there's going to be withdrawal symptoms? That piece I'll show you in a second what that looks like when we score it. So that's one dimension you're gonna look at. The second dimension is biomedical conditions and complications. This is also in relation to the withdrawal. So if they were to stop using today, is their withdrawal symptoms gonna be significant enough that there's a medical condition, a medical concern with that? Or do they have some kind of medical condition that withdrawing from the substance may lead to some kind of medical reaction? So paying attention to what kind of maybe medical conditions are also interrelated, and if their substance use is significant enough that if they were to stop using today, it's going to cause some kind of medical complication. The third dimension is the emotional behavioral dimension. In this dimension, you're really looking at, is there a mental health issue that they're dealing with? Are there risk factors? Do they have extreme impulse control issues? Do they have suicidal tendencies or homicidal tendencies? Is their mental health stability just not strong enough that if they were to stop using substances today, that there's not some risk for harm to themselves or somebody else? The fourth dimension is their readiness to change. At any point, and we'll go through kind of the stages of change discussion a little bit later, but anytime somebody's coming into substance abuse treatment, drug and alcohol treatment, you really have to gauge where they are at wanting to make a change at that point. Are they wanting to become sober? Are they wanting to stop using? The difference with this really for adolescents and adults often is what I always call kind of internal versus external motivation. Adolescents are not independent adults. If the court's telling them they have to engage in treatment, if they have a family system, their parents are making sure they're coming to treatment, that's an external motivation that's making sure that they're going to get there. That's not necessarily going to change right up front what their internal motivation is, but it at least is going to get them to treatment. When you're talking about an individual independent adult, if their readiness to change and their motivation internally is pretty low, it's a little bit more difficult to get them to come into treatment. Dimension 5 is relapse, continued use, just continued problem potential. This is just really where are they on their commitment to maintaining their sobriety or preventing relapse? Where are they on that engagement of sticking with a relapse prevention plan? Sometimes you're looking at individuals, a lot of times in the adult system, that maybe have tried before and have relapsed. So, on Dimension 5, they may have a higher score because they've attempted to get into treatment before and they've relapsed. So sometimes their readiness to change is even a little bit lower because of that. And then Dimension 6, recovery and living environment. This is also a dimension that's significantly different for kids than adults. Obviously in adolescence and youth, when you're talking about their living and their recovery environment, it's about their family system and who they have as a support system, their parents, their relatives. They're dependent, so they're very dependent on that support system to get them to treatment, to help maintain their supervision, everything that would come with a relapse prevention plan. As an individual adult, it's really going to be as much about their support system, but a lot of times they may be living individually and don't have as much of that external kind of motivation that's maintaining that safe environment for them. A lot of times it's really up to them on that environment and establishing that safe environment. Any questions about that?
One thing we probably didn't mention is that we're really pretty informal people, so don't feel like
As
you
I'm
have to-
sitting on the table.
So don't feel like you have to sit and stare at us like zoo animals. If you've got questions, if things are popping in your head, and if you have any yeah, but thoughts, those are always important. I encourage you to shout those out. Yeah, I get that, but what about X, Y, and Z? Don't be afraid to ask those, okay? Because there's a lot of misinformation when it comes to drug and alcohol treatment. And so we see a lot in the media. For instance, who's the last celebrity you heard about entering rehab? There has to have been somebody this week, right?
Or just got out.
Or just got out. I saw an article today about Johnny Manziel,
Yeah.
right? Okay, Lindsay Lohan, however you say her name is, she was in rehab every other week, it seemed like. You know, it begs the question, is that what alcohol drug treatment is? One of my favorite quotes, and it was actually a parent ripped this out of a magazine in a private practice lobby where I was working, which I thought was interesting, gave it to me as a gift from our own lobby. It was a quote from Michelle Pfeiffer. You guys know who Michelle Pfeiffer is? I know Mike knows.
Oh my gosh, that's really just aged me.
Yeah, Michelle Pfeiffer, famous movie actress. Said, you know what? My husband and I are just regular people. We're like anybody else. We try to work hard, make a living, save enough money so we can pay for our kids' therapy. You know, there's a lot of folks that suffer silently, whether with their own children or themselves as an individual, that aren't on the front page of any MSN or whatever your Google that you're checking out on the news. It's not the Johnny Manziels, the Lindsay Lohans. Lots of folks enter treatment and do so on an outpatient basis, and they're very successful. They maintain their sobriety the same way anyone else might, without having to go to somewhat of a locked facility. So there's a bit of my whole point, going a long way to just make that point, that there's a lot of misconception about what drug and alcohol treatment is and what it is not. So feel free to interrupt us, feel free to interject at any point, okay?
Thoughts, questions?
Was, you mentioned that the children, adolescents were less ready to embrace change than adult counterparts. And I find that a little bit surprising. Maybe I misunderstood what you said.
And I don't know that they're less ready. I think the difference, one of the major differences in adolescents versus adults is there's a little bit more of an external motivation for adolescents because they have a legal system and parents perhaps that are making sure they get to treatment. On an adult level, there may be a legal system at some point through that, but a lot of times it's really up more to them independently as an individual to get to their treatment versus the adolescent.
I see, so it's that internal readiness.
Ready,
Okay.
yeah, that they're willing and ready and get there, and it's really that motivation factor. I think a lot of times kids, and we'll talk a little bit about it with the stages of change, but even for adults, I think, the readiness piece for recovery for adolescents is sometimes just impacted by age and knowledge and experience. I think understanding kind of the negative impacts and the cons, I guess, of being involved in substance use they just really don't understand how much it impacts their life long term, and so that kind of that impulsive immediate thinking that adolescents experience really impacts where they fall on that stages of change or readiness to change with the treatment piece. I think for us, a lot of our kids that we have that come into treatment, and you mentioned it was 9%. Was it 9 or 10? I wasn't 9.
Yes.
That was
It was really close to the
I
right
know,
answer.
it was with the standard deviation, but with juvenile court, there's such a small percentage that really come in at that level, and so A lot of those kids, when you're talking, there's 9% of kids that are coming into court because of that, there's oftentimes a whole lot of other environmental factors involved as well. That kind of impact that readiness to change, because I think they look at, what I'm doing is not a big deal compared to maybe what's going on around them too. So I think there's so many factors that influence youth and their kind of where they are in that stages of change continuum and their readiness level. But I think the big piece is that difference of there's oftentimes a very strong family system or some kind of system that's really pushing that, where with adults that's not as much the case. A lot of times if adults come into treatment, if they decide to stop treatment, they can stop treatment. If adolescents decide they don't want to come into treatment, they may have a judge or a probation officer or a parent saying, no, you're coming, we're going to continue to go. And I think for the adult, obviously if they're involved with the court system, there's also that motivation there, but not all adults coming into treatment have some kind of legal tie or probation that's really pushing that.
So a couple of concepts then that you hear Melissa mention. One is that we keep saying kids aren't little adults, and what does that mean? When you all turned 18, at least 18, okay, 20, I got you. So we call that the age of emancipation. You're free. You're an adult. You get to live independently. You get to make your own decisions. You get to go to war. You get to buy cigarettes. You get to, you're an adult, right?
For now.
When you're 18, yeah, for now.
Right. And make it to 21.
What state is this?
California.
California,
To be
talking.
21 is the
Yeah.
legal age for cigarettes.
I wonder if that's true of the medical marijuana. I don't know, we'll look into that. But at any rate, you're independent. In fact, in the legal system, they refer to folks under 18 as being dependent. So, just think about those terms. As a child, you are dependent. You require your external environment in order to survive. We oftentimes use the analogy of a solar system. When you're a child, you're the sun. You're the S-U-N, the center of that universe. Everything else is sort of layered around you. That's what. It's all right. We encourage fiddling. It's all right. Keeps your attention. So, there is a lot that's required in order to keep a child on track. It's just the way it works. And so that's a fundamental concept with thinking about alcohol, drug abuse treatment and how important those layers within that solar system are, versus an adult who is independent. And they live on their own, has their own job, makes their own decisions. I make the money, I pay the bills, I do what I want, right? So there's a fundamental sort of societal difference as well as kind of a biological difference there. The other concept that Melissa is referencing just evaded me. What was the point I was going to make? So the first is just the difference between dependence and independence. I think the other point she was getting at was Psych 101. Is everybody taking Psych 101? Right, general psych? You remember the terms intrinsic motivation versus extrinsic motivation? That is to say, where does my motivation reside? Is it intrinsic? Is it within me? Am I the one motivated to do this thing, whatever this thing is? Or does that motivation come externally? And so part of what she is referencing is that concept of the adult versus the child. For a lot of kids that enter treatment, that motivating factor is, I'm not going to get a play in the basketball tournament if I don't go to this class, this drug and alcohol education class. I have to do it. I'm forced to do it. I'm not going to get to rejoin the hockey team if I don't go see a drug and alcohol counselor, okay? Those are extrinsic motivating factors. And Melissa is going to talk a little bit more about these stages of change in a second that'll help sort of further illuminate this point, but I just wanted to sort of echo what she's talking about there with regard to the where's the motivation. And so for a lot of kids, that tends to be more extrinsic simply because they are dependents. They rely on their little solar system, those layers around them, to make a lot of the decisions for them. And so that happens to be where some motivating factors reside. It's not to say that they can't be intrinsically
Have you
motivated.
ever had a kid though that was purely intrinsically just asked to come?
Absolutely.
Or-
Absolutely. Yeah, it's not to say that it's mutually exclusive. But just to kind of further the point that Mike asked, that's kind of where that was coming from.
And I think just a teaser on the ROS stuff that we'll talk about later, there's a big piece of ROS that's about resiliency in youth. And those are the kids that have established some type of resiliency throughout whatever experiences they've had throughout their lives. They've been able to develop this resiliency to get through those events. And so they may not have that real supportive family system, and so they have developed kind of that more internal motivation on their own because of that resiliency that they've developed throughout all of those events. It obviously does happen, and those kids can be probably more successful than others. Where that piece comes in is when they get to recovery, what type of system they've established for support, because that resiliency doesn't last forever, and it ebbs and there's lulls and you get tired. So that support system and that peer support, whether it's peer support, community support, whatever is established is very, very important. It's important for everyone, but those youth that have probably not a real close natural support system, that have come to it on their own, that's so important, that kind of that relapse prevention piece that we'll talk a little bit about in the IOP programming. One of the social supports is a key piece to that, to make sure that they maintain their sobriety. One thing I wanted to mention, just because the opiate epidemic is so it's overtaking us. I think we're just dealing with it on every level. Dimension 2, it's always been a question regarding kind of a withdrawal. Has anybody heard about when people are withdrawing from opiate, what that is like? Has anybody heard? Can you, like how, an individual who is coming off of a high, have you had anybody, or has anybody explained to you what that feels like to the individual?
A lot of high anxiety, paranoia, terror.
Right.
Yeah.
It's pretty significant, I think, which is why the addiction is so strong, and why the relapse potential is so strong for opiates, is that withdrawal from it is painful. A lot of people will explain, just recently my son came home from school and said somebody came to present who was a heroin addict in recovery, and explained that he was laying in the ditch for 2 days before he came out of whatever, came completely out, vomiting, your head hurts, your chest hurts, to the point that you feel like you're going to die. But if you ask a medical professional, they will tell you, you will not die just from coming down from a heroin high. You feel like you will, but you will not. So there's always a lot of discussion around that biomedical piece when you're talking about the heroin and the opiate issue, whether they need hospitalized during that time period that they're going through their withdrawal, or whether it's something that they can do at home in the community, just because it's such a significant withdrawal effects from that. So they don't need medical for that, but they probably will think they do. But it's also a huge contributor of why the relapse is so strong with that addiction, because it's so painful for them.
That's exactly the anxiety that you described. That is how anxiety feels.
Oh yeah, it's
And sure you've seen it in your years of practicing as a therapist, that you've had people in my office literally thinking they were going to die because they were having a panic attack. And that's just a panic attack, not to say nothing of the anxiety one feels during a period of withdrawal. So you're absolutely right.
Okay, so any more questions about this at all? All right, so now I'm gonna go to the comp.
Again, the ASAM is the American Society.
Addiction.
Addiction. Gee, Christmas. Help them out there, because I think it's important that you understand the science and research behind this, with who ASAM is.
Right, so American Society of Addiction Medicine has developed these dimensions to determine the levels of care for substance abuse, drug and alcohol treatment. So this next slide is just a small tidbit. I have the 6 pages of what it actually is. So if you kind of see on the far left, the 1, 2, those are going to be the 6 dimensions that we just went through, all of those different categories. The 0 to 4 on the top is actually how you score it. So you kind of do, hello. You kind of do just a little comparison. You're going to go across when you're looking at the withdrawal potential in the first dimension, where they would fall based on, are they fully functioning, demonstrate that they likely will not have much withdrawal. They're going to get a 0 score. If they're at the far end of withdrawal is likely, they're going to get a 4 score. The second category is the biomedical. They're functioning, there's not a lot of medical issues, no concern for any kind of medical reaction, they're going to get a 0 score. They're on the far end that they need some kind, if they were to stop using, there's going to be some medical reaction, then they're going to have a higher end score. So you're going to do that for each one of the categories of all 6 of those dimensions and get kind of a score from the 0 to 4. It's really sort of this, once you do it a while, you get really good at knowing what they look like and who the categories are. So it's not as cumbersome as what it looks like on this. But it can be timely, and I think the important thing is it's so important that assessment and you're asking the right questions, and that assessment piece is so comprehensive that you're scoring them on the right categories within these dimensions to make sure they're into the right level of care. Obviously, that doesn't mean you can't shift if new information comes, but.
One thing I'll point out is you see that that's the heading at the top, it's an adolescent risk rating. Would we be preaching to the choir if we asked you all about the differences between a 16-year-old versus a 13-year-old? You've had a little bit of schooling under your belt and recognize that maybe a little bit from a textbook standpoint. But I mean, just think about it. A couple of years ago, my son was in 7th grade playing basketball. The difference between the 7th grade basketball players and the 8th grade basketball players. We'd watch the 7th grade play and they'd all go, and they still look a little bit like little kids, and some of them even have a little chub on them, the baby fat. And the next team comes out, and they're all hairy and muscly, and you're like, what the heck? What happened in the locker room? These kids, 1 year difference. So the difference between a 12-year-old who's using and a 12-year-old brain, the difference between a 16-year-old body, 7th and 8th grade. I mean, the difference between a 12-year-old and a 16-year-old is not just 4 years. It's significant in terms of brain development. You all know this, right? So again, I don't want to preach to the choir, but it's terribly important that we underscore this fact that where a 17-year-old is developmentally, both mentally, physically, versus a 15-year-old, as Melissa mentioned, their health history, their medical history, all of those things are so important in terms of an appropriate assessment. I won't mention any specific entity. I will simply tell you that we work with 6 hospitals across our region doing crisis screenings in the emergency department. We just learned this past week one of the EDs is using an adult screening tool for kids when they come in. And once we started, and these are medical professionals. This is a hospital. Once we started talking about some of the research-based tools that we use and the reasons for those, you could see these light bulbs go off from an administrative standpoint. And they said, why in the world are we using this tool and applying it to children? We know better. It makes no sense. And so, as it relates to the assessment piece for kids, it's terribly important that if somebody comes to us with a drug and alcohol issue, that we're utilizing not only the right tools, but we're taking into serious consideration the background, their history, social history, health history, medical history, and rating them appropriately. It's not as easy as here's the tool, chalk it up, you use your own subjective judgment. There's a lot of research and science behind it, and it's terribly important, as Melissa will talk about in a second, to utilize that information to determine where the level of care is and the proper intervention level, what type of treatment they need. Because some people, I'll be honest with you, they need that Johnny Manziel, Lindsay Lohan, send me off to a ranch for 6 months. Other folks don't. And so it's important that we have a solid assessment, developmental assessment, in order to make that determination. Does that make sense?
As a therapist, we know significant issues with the relapse of Lindsay Lohan and what will probably relapse of Mr. Manziel. They don't change their environment, they go right back into where they came from. Which we'll talk about that in some of the treatment pieces that we go through, but funny story, ladies, on the crisis screening tool that this particular hospital was using for adults and adolescents, you score a point just because you're a female as a risk factor. So, yes, I go, I'm not sure that's probably accurate anymore. Where did you get that screening tool from? So, they weren't sure, and so we're going to work with them and have a little bit improved process specific to adolescents, because it's so, it's very different. I think, we talked about this a little bit earlier about, the differences between youth treatment and adult treatment. Kind of the idea behind treatment is not different. The philosophy of treatment is not different. It's really more the approach and the systems that are involved that's different. Obviously, and if you haven't heard, I'm not sure how many have heard about trauma-informed care in your world. It's a huge buzz. It's significant. What we know about at any point if a youth experiences trauma, their brain development freezes, pauses at whatever age they experience that trauma. So at the age of 12, they experienced a significant trauma, either an accident or a significant death that was traumatic to them, which is also a whole other continuum of what's traumatic to you may not be traumatic to me because of those resiliency factors. So it's a fine science. But the idea is that at that point, if they experience trauma at the age of 13, their emotional development has paused. So you may have a 26-year-old who is really processing a lot of things in their life at the emotional age of maybe 13 or 14. They'll still advance, but it's going to be very delayed. They're not going to be at a 26-year-old emotional developmental level when they're 26 if they experienced a significant trauma at the age of 13. So in that assessment process, it's also thinking about, where are your interventions? How do you need to work with your interventions when you know that somebody has dealt with a traumatic experience and their emotional development is really not where the chronological age is. So that's just another big piece to the puzzle. So obviously, we're going to go through these 6 dimensions. We're going to score them. And then they're going to fall into some category of treatment. This is where the levels of care come into place. Each different type of treatment is within a certain level. Level 1 is outpatient treatment, typically once a week, maybe bi-weekly. A lot of that work, those are folks that are probably on a higher stage of the change, higher level of motivation for treatment. Level 2 is our, when we talk about our intensive outpatient program, more intensive treatment, or partial hospitalization. We don't provide partial hospitalization, but really what that is, they're going to treatment for, I think it's 5 hours a day, every day. It's not residential, it's kind of one step back from residential. You're not staying or sleeping there, you're going for treatment every day and then coming home in the evenings. But, and then obviously the level 3 is more that residential hospitalization type of level of treatment. So when we're scoring that, obviously you can see it's telling you if dimension 1 is the score, then that is how you determine what level of care that's recommended for that particular youth. This is specifically the youth adolescent dimensions and levels. There is one for adults that's going to be similar, but the scoring may be different, and some of the descriptions and the categories are going to be different and be a lot less specific to their family supports. And some of those factors, it's going to be really more about them as an independent adult. Any questions about that? Okay, so I'm going to talk about our outpatient treatment and our intensive outpatient, knowing outpatient is a level 1. We only provide up to a level 2 at our agency. If kids score at a level 3 type of category, obviously then we're referring them out to that level of treatment, to some facility that that we can work with to get them in. And usually those treatments, residential treatments, are maybe a 60 or 90-day treatment, so they can work down a level. So they may go to residential treatment for a short period of time and get some of their symptoms under control enough that now when they do that type of ACM assessment and level of care, they may only score at a level 2 or a level 1. So the point of residential treatment is really just to help stabilize and get them to a lower level of need, so that they can come back to the community, come back to their home and their family, and then work on their treatment at that level. Okay, who's going to talk? All right. Just checking to see if there were more clicky. So let me talk about our outpatient, so the level 1, the outpatient treatment. In outpatient treatment, typically the types of interventions that we're going to use usually fall into 2 categories. You can do lots of things, but usually you're utilizing a motivational interviewing type of intervention or some cognitive behavioral treatment. With motivational interviewing, my cheat sheets in case I forget. In outpatient treatment, so the motivational interviewing, you're working with a patient, and the main piece to motivational interviewing is really to motivate them through the stages of change, increase their level of motivation. It's really, it's actually the interesting thing about motivational interviewing is oftentimes it's just a conversation. There's not really tricky interventions to it. We're not doing behavior plans. We're not doing anything real significant like that. We're having a conversation with them. We're displaying a lot of empathy about what they're experiencing with their recovery, with their addiction. Additionally, we may challenge them a bit. What we're trying to do is develop some kind of discrepancy in what is it ultimately you want out of what are your goals? How is your behavior and how is your substance use helping you to meet those goals? And really getting them to see that, what type of behavior and what they're dealing with right now in their substance use is not getting them to where they really ultimately want to be. It's not confrontive. It's not, it's not a legal approach of saying, do you understand if you don't do this, you're going to jail? It's not a punitive approach. It is really a conversation of trying to understand where they are and their understanding of, of their addiction and how it's impacting their life and their family perhaps. And really, in therapy we talk about what's the magic question. If you could pick one thing or be in one place, where would you like to be? Motivational interviewing really challenges that. Where would they like to be? What are their goals? How is what you're doing now getting you there? Well, if it's not, what do we need to change to get you there? What do you think needs to change first to get you there? And really make them see the plan and lay it out just by having that conversation. I'm not giving you tips, I'm not giving you advice, I am really drawing it out of you through that conversation and kind of challenging what you're doing now doesn't really match where you want to be. With motivational interviewing, if you have a resistant client, they don't want to be there, they have nothing to do with wanting treatment, you're not going to stop treatment, you're not going to tell them not to come back, you're going to continue to have them come back, you're going to continue to have those conversations, and eventually they're going to get to the point where they're going to start to see that distinct difference in what they really want out of life and what their goals are and what they're doing and what's happening with them right now based on some of their decisions is not getting them there. So how do you change that?
Kind of like Dr. Phil, how's that working out for you?
Right.
Yeah.
Yeah, exactly. In a less, Dr. Phil. But that's exactly when there's nothing more powerful than having them see that path and really, filling in the blanks themselves. And motivational interviewing is, you hear about it a lot and it seems like this mystery on what it is, and it really is just a conversation. Maybe even like you would have with your friends who are saying, I really want to do this, I really want to do this. Well, what are you doing to make that happen? Talk to me about what needs to happen and make them tell you the plan. Motivational interviewing may have a lot of silence because it's not you giving directives, it's them really developing that directive themselves.
Just hearing her describe that, does it bring forth any examples in your own mind? Can you think about anybody? Don't share it, I guess, out loud, especially if it's the guy next to you. But I keep coming up with this Johnny Manziel thing in my head as I'm listening to her talk about this.
Poor disgruntled Browns fan.
I'm a Steelers fan. I don't even understand.
You're a happy
I'm sort of fascinated by the whole thing because here's a guy that's sort of got the world by the tail. Could do whatever he wants, but lets that behavior get in the way of what he wants to accomplish, and fails to see it. Why? Because I assume I'm making some assumptions here, but because I'm in control. I'm in control. I know what I'm doing. And a short stay at the ranch in the mountains doesn't necessarily get rid of that. And it's not to discredit wherever he went for rehab, but it's sort of like cramming for a test. You all know this, hopefully, from psych or ed psych or something. The quicker all that knowledge, the quicker it's going to be lost, okay? Weight loss, the same way, okay? Yep.
So what do you suggest for him?
What would I suggest for Johnny Manziel? He needs long-term treatment. And we live in you like when I get put on the spot.
No, I have my thoughts, I'm waiting for you.
All right. In our society, we like a lot of quick fix. And for folks that can pay, there's people out there that'll say a quick fix. And we have to be very cautious of the snake oil. It's one of the reasons I got into our field. I started out as a chemical engineer, by the way. Took a great deviation, into psychology and therapy. But we like a quick fix, and if you get the money, you can pay for it. And there's all kinds of hokey people in our field that'll sell that snake oil to you. But what sort of sustaining change did you create? That's the real question. And I think when you cram for a test, sure, you may do well, but do you retain the knowledge? If you're looking for a quick fix in terms of treatment, you can go on the Dr. Phil show. But how many of those families were fixed 2 months down the road? What's the rate of success down the road? If you notice now, I have a big soapbox about Dr. Phil, by the way. It's kind of interesting you brought that up. If anybody watches the show or used to watch the show, you'll notice, and I know this from years ago. Actually, I worked in a private practice where every day, I think it was at 4 o'clock, in our lobby, this medical practice, Dr. Phil was on. I'd come out to get my patients at 4 o'clock, and they were all sucked into Dr. Phil. It's kind of ironic. But in the early days, he didn't talk about this. He talks about this now. Always links people with counseling or therapy in their home communities. He talks about that, before things, the curtain call, right? Because there's no sustaining change. And so, it's kind of a long-winded answer to a short question, but it's tough because right now I don't think Johnny Manziel has that intrinsic motivation. And even the extrinsic motivation that he had, owners and coaches and everybody around him, wasn't enough to really get him to that point in the stages of change where he needed to be to make that a long-lasting therapeutic change.
Him going to rehab for a period of time is going to be like the start, the tip of the iceberg for him. Recovery is a long process. And so I think there's a misconception, and it's mostly probably in that kind of society of Hollywood and sport athletes, etc. You can go somewhere for 30 days and that's it, that's where it ends. That's really just the beginning of the treatment. That's to get them sober, that's to get them started, but if there's not any maintenance from that point, they're gonna relapse just because it's a long process. It's not something that happens in that short of a period of time. It's a lifetime for them, and so to even get to a point where there could be a longer period of sustained sobriety before a relapse, because relapse usually happens in treatment multiple times, they have to be committed to that long-term piece. And I think for him, and for many, it's just, I have to go because I have to go, so I'm going to go do my 30 days and then come back and think life is just going to pick up where it does, and it does, and then they fall back into the same patterns.
I'll also add 2 comments. One is that I really encourage you all, if you have an interest in this, to make sure you attend the session. I saw Dr. Brad Bundy is going to be here and talk about addiction in the brain. Dr. Bundy does a lot of significant research on the addictive neurology, the pathways, neural pathways within the brain with folks who struggle with addiction. He's got some great research behind that, and I'm sure he'll share some really neat things with you as it relates to the brain and addiction. The other thing I'll mention is that, we talk about treatment being and recovery being a lifelong process. Perhaps another analogy is that we work and get involved with a lot of kids who, because of a mental health issue, end up being placed in the hospital for a psychiatric admission, or suicidal, for instance, or attempted suicide. In those cases, a lot of times kids will go away to a hospital because there aren't any around here anymore. Toledo, Dayton, Columbus, Fort Wayne are our closest. Typically 3 to 5 days. Some residential treatment facilities will hold kids for up to 30 days. Whether it's 3 days or 30 days, if they're a child known to us, we have a good collaborative relationship with whoever the hospital is, we start planning right away for their discharge. So even if we know they're going to be in a facility for 30 days, we immediately start planning with that facility what their release plan is going to look like. You can't just go and get that level of intensive treatment and then have it stop. It really has to be stepped down. And so that can take place within the community, as Melissa was just alluding to, with our outpatient counseling. I think I probably interrupted you about the point where you were going to talk about our intensive outpatient. All right.
So we talked about the motivational interviewing piece of that. The cognitive behavioral therapy piece is really, a lot of those interventions are when folks are coming in, kids are coming in, and they're really more into the level of commitment to change. They're at a higher level, at the stages of change, a higher motivational level. So at that point, you're really talking with them about what are your triggers to use, what environments, what locations, what friends, what social activities are triggers to you using that substance, whether it's marijuana, whether it's alcohol, whatever it may be, whatever substance that is. What are those common points that you are using, common times of the day? And what does your day look like if because it's part of the brain chemistry, if at 8 o'clock in the morning, every morning, you're using a substance, until you break that pattern, that's when your body is going to expect that substance and there's going to be some kind of reaction. And so you're really working with them on changing some of those plans. What's the triggers? What's their schedule look like? Where are they going to be? If a typical place where they're going to use a substance is, say they go to bowling every Thursday night, that's a bad example, but bowling every Thursday night, and that's where, where they're using alcohol all the time. That's their common theme. They're going to have to stop doing that every Thursday night. They're going to have to find something else to replace that. That's more of a positive type of activity. They have to change their schedules. They have to change their environment. They have to really plan for when they're having those urges and those cravings. What are you going to do? When you start to crave a substance and start to crave using, what is your plan? What are you going to do? Who are you going to call? What are the activities that you might do? You might go take a walk, or you might call a friend to go take a walk. What is your plan for that? So when you're working in an outpatient setting with kids, and this is similar to the adult, at a higher level of motivation, and that cognitive behavioral piece is really changing that way of their thinking and how they're planning their days and working that relapse prevention plan. You're developing that plan with them and you're working it regularly. They're coming in to see you, you're checking in with them, making changes as necessary, seeing how they're doing with their plan, just to make sure they maintain that plan and keep up with that. And they have the right supports in place to make sure that that happens. So any questions about the outpatient piece? I think what I don't, because you're seeing pictures, what I don't want to dismiss is, a lot of times our adolescents may have and adults too, a comorbid mental health diagnosis along with it. So they could be dealing with depression, they could be dealing with anxiety. Those are very common for adolescents who might be using marijuana or alcohol. So one of the, kind of historically, and Josh may be able to say this too, there's always been this debate, it's kind of the horse before the cart. Do you treat the mental health issue first, or do you treat the substance issue first? When you're dealing with somebody who has both of those comorbid conditions. Typically, what we say is you have to make sure they're sober. You have to make sure they're not using substances to really determine, is there a true mental health condition, or is it just some kind of side effect from the substance use? We have, and we'll talk a little bit, when I talk about IOP, we have had several kids that will come in to our IOP program and will be sober for a period of time. And probably, I would say, within the third week, it's a 12-week program, within the third week of IOP and their sobriety, or they've been clean, not using any marijuana, any other substance, those mental health symptoms will start to come out if they're there. So if there's anxiety, if there's depression, even bipolar disorder, those types of symptoms will start to come through. We work very closely with our juvenile court in one of our counties through their adolescent drug court. And, a lot of times there's a question of whether a child should come into the drug court because it's a drug court. It's not a mental health court. So, so the debate at that point comes, well, because now it's a primary mental health issue, should they maintain in our drug court? Should they maintain an IOP? Because it's really a primary mental health. We've come to an agreement with the courts that with that oversight, they're maintaining their sobriety, so therefore we can better treat their mental health. So a lot of times that's where, we may have to look at medication because they may have been self-medicating with alcohol or marijuana. So a psychiatrist gets involved at this point, and we may be utilizing some kind of medication management along with it. Psychiatrists, we're very fortunate to have two very good psychiatrists that are aware and understand that substance use piece, and with kids who may come to us that have had some kind of addiction issue, of that risk of putting them on some kind of medication and that interaction if they were to start using substances again while they're taking a medication. So they're very careful, and when they're looking at medicating, that it's not a medication that could have, there could be any major significant medical reaction to them if they do begin drinking again or do begin using that substance they were when they came in. So, I guess opening up, going to the IOP program, that's in our level 2. Like I said, we don't do partial hospitalization, so kids who are into a level 2 are going into intensive outpatient. Intensive outpatient is 3 days a week, 8 hours a week, 2 days they come to us. 2 of those days are just with the youth themselves, and 1 day is for parents or family and the youth together. So there's a very strong family component. The 4 major components of IOP are early recovery skills. So at this point, they're again talking about their triggers, their cravings, their environment that causes those triggers. They're working through relapse prevention plans. They literally make schedules out for their day, and when they come back in at the end of each week, they report what they did throughout the week. How did they adjust their schedule? What kept them busy? What did they do? There's also the family education component to that. So we're talking with the kids and the family about each individual kind of substance, common symptoms of, effects of utilizing and using certain drugs, how it can impact your body, how it can impact your brain. Also talking about the dynamics of a family who's dealing with any kind of substance use or alcoholism. Now, obviously, we know that a family system changes significantly when they're dealing with some kind of addiction, and it's a significant hump for families to get through that, because oftentimes family members are put in a position of making a choice of not allowing the behaviors of a loved one to continue and making sure they get treatment. Sometimes that involves, bringing law enforcement in or the legal system in, which is a very tough decision for some families to make. So really talking about those relationships, those trust factors, the communication, talking with parents about supervision. When you have an adolescent who has a significant addiction, that supervision piece is so significant. You can't just let them, go hang out with friends unaccounted for several hours when they're in the process of a recovery. They have to have supervision for a period of time to make sure that they have control over that plan. And adolescents in general, we know, are very impulsive. So that level of control that that perceived level of control that they think they have over their decisions is something that we really talk to parents about, that it's very, very important for them to maintain that supervision. Our IOP program, as I said, we work very closely with a juvenile drug court in Allen County. Our program is a piece of their program. As kids come into the drug court, they are directly referred to IOP. They go before the judge every week. They have drug screenings every week, if not more often, depending on kind of history of passing drug screens. And we're working regularly with them to develop these relapse prevention plans. Social supports is another piece. Getting them involved in a positive kind of peer environment. A lot of times the kids come to us, they're not typically using by themselves. It's in a group with other peers or 1 or 2 other friends. Unfortunately, those relationships have to end. You can't maintain a friendship with somebody who is a using peer. So we have to work through them with how do they develop different relationships, better, healthy relationships, get involved with more positive social experiences and positive social supports, so they're not by themselves. Another piece to the ROSC Josh will probably briefly touch on, and Pressure will a lot more, perhaps when she's here, is that recovery support, that peer support, that natural family support that's so important for long-term sustainability of their sobriety. If left kind of on their own, a lot of times people fall into their old coping patterns if life gets too stressful. So without support to guide them through that, a lot of times you're going to see somebody relapse at that point. Any questions about, that's about it for the IOPA. We utilize the matrix model, which is an evidence-based model for our curriculum. It's fantastic information. We've had a lot of success with our kids. We've had some kids come through where parents aren't involved, don't want to be involved, but they want to be a part of it. So they may have an aunt or uncle or somebody as that guardian or that support for them that comes with them to those family groups rather than a parent. Any questions? Any thoughts you don't have? Okay. So with that, we're going to move on to the stages of change.
I didn't see that slide.
Do you not see it anywhere? It's a swoosh.
Yeah, I remember seeing that too. I'm gonna,
Well, if you don't,
I can call it up on another Zoom.
if you want to try that, I can start talking about it while you do that. So I'll just, if you haven't seen the stages of change, it's really kind of just like a hill. Incline, a swoop, going up. There are 5 stages of change. What we're looking at in a lot of our treatment, especially the motivational interviewing, is to help move people through that, through those stages and move them up to more of a place where they are really committed to making some changes and motivated for the treatment. So the first is a pre-contemplation. Basically at pre-contemplation, that's the bottom level, there's really no desire to change. Somebody coming to us at that level, they don't really understand, they're either uninformed or really aren't interested in being informed of the consequences of their behaviors or their actions. They're just really not interested in hearing it. There's no piece to it that they're ready to change, and it's likely they're not going to really be involved or want to be involved in any kind of treatment for a period of time. That doesn't mean that some kind of external factor, whether it's a family member or a juvenile court system, may not get them into treatment, even at a pre-contemplative stage. That's where we try to work, I say work our magic, try to work to move them through those stages so that we can actually be successful with their treatment. The next stage is the contemplation stage. At this point, people have decided they're kind of interested in, thought about becoming sober, no longer using substances, but they're kind of on this fence of the work it's going to take and how difficult it's going to be still is kind of outweighing the benefits of me becoming sober. So they haven't quite come to the point where they actually realize that, that the positive outcomes of their sobriety outweigh their continued use. So at this point, you're probably, they give numbers of somebody in this stage, here we go. In the contemplation stage, may not be, they may get engaged in treatment within the next 6 months. But I don't really know how you gauge exactly that time frame, but that's kind of how it's been described. In the preparation stage, you're going to have people who have, they want to make the change, they plan to make the change, they may have already started to change kind of their peers or their schedule or talk about potential triggers or anything like that. They may have already done that on their own. So they're preparing, really it's kind of, they're preparing for their own sobriety at this point. Somebody at a preparation stage can go into an outpatient level of treatment and be very, very successful. Then we have the action stage. This is actually somebody who's in treatment, actively working a relapse prevention plan. They have natural supports, they have family supports, they have peer supports. They've maintained some level of sobriety perhaps on their own for a short period of time. but they're committed to making that change at this point and going to be very successful in an outpatient setting. The maintenance phase is, they're in treatment. They've maintained sobriety, they've worked their relapse prevention plan, they're continuing to work with their supports. They've not relapsed at this point. And typically if somebody stays at a maintenance level and continues to work a relapse prevention plan for up to 5 years, the risk for relapse is only at 7%. Anything less than 5 years, the risk is higher. We talk about, a lot of times people will say relapse is part of recovery, and that's oftentimes true. A lot of people have to kind of start and stop with treatment many times before they can be successful, completely successful, and maintain sobriety for a long period of time. It's our job as therapists and counselors to work with them to help them understand that each time that you get to this point of sobriety and that length of sobriety, so maybe the first time it's 4 months and you relapse, but you've come back and you've started over and you're committed to doing it. The next time maybe 6 months. So then maybe relapse happens. The next time after that could be 2 years. So typically what you see, if there is relapse, that pattern of relapse, that each time that occurs, the length of time between is much longer, which is the positive trend, which is difficult for sometimes people to understand that relapse can be part of recovery. And I think, the piece to relapse is a lot of times they experience, they've experienced sobriety and what life is, being sober and not using substances, and then they relapse. Sometimes it's a really good lesson to realize, this life of addiction and substance use isn't really as fantastic as that time period that I was sober. It's very easy for people to fall back into that pattern of using again if they don't have the right supports in place. So, as we talked about the Manzels and the Lindsay Lowens, and they don't have those right supports in place after that sobriety to prevent them from relapsing, and so they kind of fall into those same patterns. And kind of like anything, when the vacation's over and they've got back into their old routine, a lot of those old habits that were developed, really by your brain and your body of, when I was here, this is what I did. When I was doing these activities or with these people, these are the things that we did together. Your brain is automatically going to fall back into those old patterns. So, going through all of those stages, all of the treatment levels that we provide, from outpatient with motivational interviewing, doing cognitive behavioral work, in IOP, is really to help people move through all of those stages of change to a maintenance level, so that they can maintain their sobriety for a long period of time. Any questions?
Do you continue with them once they become adults?
Typically for us, we will continue with kids until they've at least graduated, or maybe about the age of 21. Then we may refer them into the adult system. With substance use treatment, a lot of times if you can get kids connected or even adults connected to a good kind of a sponsor or an AA group or something like that after they've gone through some significant treatment and they've been at a maintenance level for a period of time, they may not necessarily need outpatient therapy. They could potentially continue with some kind of support group function that just really offers them that peer support when they're starting to struggle, when they're feeling the pressures or the urges or unable to cope with some of those triggers. They can contact a sponsor or go to a support group that will help kind of bring that back and kind of put them back in focus. But we typically will work with kids up to 21 is usually how far we've gone, and then if that issue continues, they may transition then to our adult system.
Our role is very clinical, offering clinical treatment, but a part of recovery being a lifelong process. It's never our goal to keep people in treatment for longer than they need to be. We want to keep people in treatment for as short a period of time as possible. Much like I think a good physician that says, let's put you on the lowest med dosage where you get the best effect, right? Start out with the heavy hitters. So it's key for us to, at the end of clinical treatment, that we try to, first of all, try to keep that as brief as possible. And then secondly, link the individuals with non-clinical support, which isn't always things we provide. It may be an informal system within the family, maybe something more formalized yet non-clinical like AA, or a variety of other things within the community. So we definitely try to make that linkage at whatever point in a young person's life that is.
I think even as counselors, therapists, we also kind of live by the rule that therapy isn't always the best option. I mean, at some point, you can do too much therapy, or therapy's not the right care that's needed at that time. And I think, especially for AOD treatment, at some point, if they have all of the tools, really what they just need is ongoing support. You try to get them linked to that support, knowing that they can always come back to treatment if it's necessary, but not to over-therapy people to the point where it starts to kind of become ineffective and they become too dependent on you, and really don't internalize those motivations themselves and utilize what they've learned. So it's really kind of, linking them to those supports, and have them use the skills that they've been able to gain. Thoughts, questions?
So I'll talk briefly about, I say briefly as if it's going to be 30 seconds long. Don't get your hopes up. I want to talk briefly in the sense that I want to just kind of give you a primer about what a recovery-oriented system of care is. You have a speaker that's coming in a few weeks that's going to talk about it in great detail. So it's a passion first. But I want to give you my spin on it and talk a little bit about what's happening in this community around Ross. I want you to think of adults. Well, you know what, before I do that, just as we're talking about all this alcohol, drug treatment stuff and use, I want you to kind of go back to high school, if you don't mind. For some, that's longer than others. But if you can think
What are you
about
looking at me
That's a
for,
long
John?
I was just scanning the room. It's always equal opportunity, eye contact. Go back to high school in your mind, and I'm not asking about you as an individual, but just how many of you recall there being drug and or alcohol use? By anyone. Yeah. So you think about 99%, everybody in the room remembers that, right? How many of you remember that those that you can think of that came to mind, whether it's drug or alcohol use, you would say are addicted to drugs and or alcohol? So good. Maybe one. Okay. For the most part, we're talking about use. And there's an important distinction that you need to be aware of. And actually, I probably jumped into something that Melissa's better explaining than me. But there is a significant difference clinically from alcohol drug use, alcohol drug abuse, and alcohol drug dependency, which is where we really talk about addiction and the need for intensive treatment to overcome that, brain chemistry, etc. Alcohol use, drug use, and versus abuse versus dependency or addiction. So I want you to keep that in mind, because one of the things that we talk about, or that you hear talked about a lot, even in local paper, is this epidemic use of kids and alcohol and drugs, and it's all over the place. There is some education that's needed so that we all understand the differences of what we're talking about. I think almost every one of us could raise our hand and say, yeah, there's alcohol, drug use. I can remember back when I was a teenager, when I was an adolescent. But how many of you can also think about kids that needed and were in treatment? Next to none. And the reason for that is that difference of definition of use, abuse versus dependency. And that again is something that we do with that whole assessment piece, making sure we understand where a kid is at. Because 90% of kids who are using alcohol or drugs do not make it to treatment, either because it's not a dependency or addiction issue, or they haven't been caught, haven't violated some law, or sports rule, or school rule, that sort of thing. So I don't want to take us too far down that path, but I want you to be very clear about that difference between use, abuse, and dependency. If you think about an adult who's struggling with addiction, oftentimes the course of action, I would say traditionally, historically, has been looking at acute stabilization, usually detox, right? I was in a psychiatric practice that was affiliated with St. Rita's Medical Center in Lima for 5 years. And there was an addiction unit, and cops talk about this all the time, throw them in the drunk tank, right? Send them upstairs, let them detox, withdraw, puke all over themselves. I mean, that's I'm just being real here. And after a couple of days, they're fine, they're sobered up, now we can treat them and do better. That's kind of acute stabilization. Traditionally and historically, applying that same sort of mentality, we're looking at an acute stabilization for kids, isn't a very good process because, again, kids aren't little adults, and 9 times out of 10, kids are using. They might be abusing. They're not addicted or dependent, which is completely different. And so to treat them as if they are sometimes isn't the right approach, because they go back into those same environments, the same triggers, etc. And so in our world, and only working with kids, we understand, again, back to my solar system analogy, they're the center of the universe that involves many, many layers. And so in order for treatment to work for kids, and it doesn't matter what the behavioral health issue, if it's depression, if it's anxiety, if it's ADHD, if it's cannabis abuse, they need those layers and those support systems in order to make treatment work. Finally, the addiction world has sort of caught up, the addiction treatment world has caught up with that mentality and recognized that recovery for adults needs to employ the same sort of model because recovery is a lifelong process. And so that's what ROSC is all about, a recovery-oriented system of care that sort of spans the life. It's not just the acute stabilization, but it's also the aftercare. And it's also the lifelong sort of peer support and other systems of support. We do that with kids regardless of their diagnosis. And now finally the addictions treatment world is kind of catching on to that, saying that's what's going to work best for the adults in addiction. For kids, and I'll back up to one of our original slides, and a lot of the work that we do. Is there a laser on this one?
Yeah, it's the,
Right? Nope.
it's the green.
Okay. So Melissa talked about our prevention and education services. A lot of the programs that we provide here, you see, and they're all kind of trendy, and I apologize, these are kind of social workery titles. Word of mouth, that's actually a tobacco intervention education type thing, word of mouth. Too Good for Drugs, Project Happy, even Incredible Years in Dynaschool, which is a puppet-based, evidence-based program. Anyway, I won't get into all of them. A lot of programming there, a lot of curriculum. It's all based on what we call protective factors. So it's not just telling, it's not like DARE. It's not going in and saying, this is what marijuana is and this is what it smells like. Okay? And I'm not disparaging that. What I'm saying is that, moreover, what's important is teaching kids kind of the coping skills to deal with life's problems. That's a significant piece of what alcohol drug prevention is. How do we teach kids at a young age how to get along? How do we teach young kids, I was going to say girls, I apologize ladies, things start to get clicky in junior high and folks start to feel, that's where I'm looking for, left out. How How do I deal with that? If I got a best friend that all of a sudden says, I'm not gonna be your best friend anymore. You know, the whole LeBron James situation recently, I'm gonna unfollow you on Twitter, I'm gonna defriend you on Facebook. You know, how do I handle that as a young person? It's important that we've given kids protective factors, predominantly coping skills, conflict resolution skills, self-confidence skills, so that when faced with life's decisions, life's problems, and then decisions about how to deal with those problems, which could include drinking, drugs, promiscuity, putting themselves in harm's way, that maybe their decision is a little more positive. So a lot of developing a good system of care is making sure you have that element within your community. I'll tell you that in Hancock County, there's a lot of financial investment, and not just financial investment, but investment on the part of, say, the school systems, for time to be set aside for those programs to take place right alongside their regular curriculum. That's an important piece of having a healthy community. And so then obviously the treatment and then the aftercare that we talked about. So real quickly, does a recovery-oriented system of care, shifting that model of acute stabilization to that sustained recovery management. It does apply to children and adults, as I just mentioned. Yeah, go ahead.
On that, you just mentioned evidence based on like the drug programs for schools. Didn't it take them like 15 years to figure out DARE was bad? So like, how do you know if they're actually good programs? Because a lot of those weren't around when I was in high school or younger. So how do you know that they're actually as good as evidence-based, I guess?
Yep. To your first point with regard to DARE, what the research really pointed to was that it was neither effective or harmful. It was just sort of there. So I mean, it was completely neutral with regard to its relevance. And you're right, longitudinal studies are what's necessary to know whether preventive programming works. I always use the YWC or the YMCA as an example. Does exercise help your heart? You'd all answer your little clicker true, right? I mean, you exercise, you're gonna be a little healthier. It's sort of just a given. We all know that now. Are cigarettes bad? True or false? You give your clicker, true. They're bad. We all know that now. Back in the 70s, cigarette trucks pulled up in front of college campuses and went like this with cigarettes, cartons. Got people addicted to them. That's what occurred. Back then, we didn't think about it being bad for your health. So longitudinal studies are necessary to know that. And help me out, PRI, the Prevention Research Institute. I'm trying to think of where it's based out of. So what's it called? Life risk reduction
Risk reduction
model is what we most closely subscribe to, because they have done the most advanced longitudinal studies about prevention work. And so most of the programming that we provide, that I was just highlighting on that left column, are rooted in that research, which is very different than DARE. In fact, a lot of times when we go out and talk about a prevention program, that's a question we frequently get. How does that differ from DARE? Isn't DARE like ineffective? So it's a common question, and you're absolutely right. And so what we've done is sort of align ourselves with where the deepest research, the most longitudinal research has been done.
I think for DARE too, just to add, DARE, if you took the snapshot of just how effective it was at that time, DARE is not a long-term, it's not ongoing year after year after year do they get information. And it's very much just about the facts about substance use. A lot of these other programs are really targeting more of that resiliency factors of developing those skills so that they know how to say no, and it's more of a long-term training process. I mean, kids are getting that that curriculum year after year after year, rather than kind of a one-time sort of shot. So I think it's the outcomes that are measured, and probably more of the skill development that's produced from the curriculum versus what DARE was more of an information kind of providing program.
So, just to wrap up, what we do across the board, and it has to be the case for drug and alcohol treatment, has to be family driven. You've got to include those extra layers of support around that individual, that child. It has to be developmentally appropriate, as we talked about. You all know that the brain continues to develop in the early 20s, if not mid-20s. So it's got to be developmentally appropriate, culturally nuanced, individualized, focused on resilience, strength, and empowerment, not a disease model. It's also crucial that we have a full integration, the continuum that we showed you with that slide. Primary prevention, early identification and intervention, which may lead to clinical treatment, and then eventually non-clinical recovery support. Cigarette smoking is on the decline, tremendously. Did you all know that? Okay, as compared to 10 years ago, as compared to 20 years ago. More people are exercising, right? Okay, so if across the lifespan we know drugs are bad, alcohol is bad, this is what it can kind of do to you, then eventually we continue to be a healthier society because of it. And the recovery-oriented system of care and what Hancock County is doing, hopefully over time, that will be proven through the county health assessment, which they have to do by law every so many years. I want to say it's every 3 or 5 years. So there are a lot of measures in place that presently kind of keep track of that. Our information, in case you have more questions, you're interested in things beyond this presentation, what we could offer you today. I'll close by asking if there's any additional questions or discussion points, or you want to know what I really think of Dr. Phil, or anything at all.
Ask him if he's really a doctor.
Be quiet. Anything?
What do you think of Dr. Phil?
You had a question too. I'll get back to that. Yeah.
When do you think parents should start talking to their kids about like drugs and staying away
Great question. When should parents start talking to their kids about it? There's actually a Start Talking campaign that the State of Ohio Department of Mental Health and Addiction Services has recently released, I don't know, maybe a year and a half?
I think they're in their second year of programming.
Yeah. Called Start Talking. I don't know if there's an exact age. It comes to mind for me. One thing I will tell you is that parents frequently think that talking about bad stuff will just elicit it. That is not true. We see it happen a lot around the issue of, it's a little bit tangent, but around the issue of suicide. And unfortunately, our region's been riddled with a lot of suicide recently. We respond in those situations, and I won't get off on that tangent too far, but parents frequently think when a school, their son or daughter's school has experienced a suicide of a fellow student, that they should not talk about it with their child because they're afraid it will plant those seeds in their head. The reality is they're already thinking about, or they already know about it. Using the word isn't going to make it automatically happen. We encourage people to talk very openly with their kids about all issues, including alcohol and drugs. And I think I'm not going to answer your question directly because I don't know in terms of the right age. But I think making good decisions and bad decisions starts, as soon as they understand the difference. When we're telling our 3-year-olds no, don't stick the tweezers in the light socket, that lays the foundation for making good decisions. So
I think that if there's not like a set age that you should start talking about it, but I think the rule of thumb would be if your child brings it up and maybe they're 4, so you talk about them at their level of what they're asking you. Most schools, once kids are in kindergarten, are doing Red Ribbon Week or something of that sort already at a kindergarten age level. So they're getting information, so as soon as they're gaining it, it's time to start talking about it. But if it comes any sooner, if they bring up that conversation or that topic, or ask a question, that's when you need to answer those questions and talk about it. So there's really not a set age, but I think it's just knowing that that there's not a too soon age. Is probably the best answer. If they bring it up, then could talk about it. You know, but once they're in school, most schools have some type of curriculum that is around kind of drug and alcohol awareness from kindergarten on. So they're going to get it at a school age level for sure.
Dr. Phil. I'll tell you two things about Dr. Phil. I used to teach psych. One of the things I always told my students was that the problem I have with Dr. Phil is he's often not wrong. He's 9 times out of 10 right. The therapeutic process doesn't happen on TV. It doesn't happen in front of a crowd. And we used to have people come into therapy. I actually worked, for those of you that remember your psych classes, you may remember a stage theorist called named Eric Erickson. And I actually used to work with a psychologist who trained directly under Erickson. And great guy, he told me this story one time. He said, you know, guys come into therapy and they go, what's wrong? What's wrong with my situation? What's wrong with my wife? What's wrong? Why? You know, fix this. You got all these damn books around here. Surely the answer's somewhere. That's not how therapy works. I'll leave you with this story. There, a famous psychologist that was asked one time, how do you define therapy? And he said, when I was a young boy, I was walking home from school. We were country kids. Me and a group of my friends were walking home from school and looked out in the pasture, and there was a horse standing. And I said, I'm going to go take this horse back to its owner. My friends said, what do you mean you're going to take it? Okay, whatever, and they left. Went and grabbed the horse. A few minutes later, he's on the front porch of a nearby farmhouse. Knock, knock, knock. Farmer comes to the door. He says, is this your horse? Farmer looks around and says, well, yeah, that's my horse. Where'd you find him? Well, he's in the pasture. Well, how'd you know it was mine? Well, I didn't. Well, how'd you know where to take him? He said, the horse knew the way. He just needed somebody to grab on to the reins. That's the process of therapy. And we have to help folks recognize their path to get to where they want to be. Telling someone the answer the second they step into your office, or telling someone what their problem is on a stage in front of a crowd isn't the true therapeutic process. It's a very intimate process, and it's about patient recognizing what their need is and where they need to go, and discovering how to get there through a guided discussion. And so, to happen on the stage and under the lights of Dr. Phil isn't necessarily our craft, and that's the bigger issue that I have with it. So, thanks for entertaining my soapbox on that.
So I think I've got this back on track now. Sorry that I dropped that one slide for you guys. But you guys ready for your final exam then? All right, let's see how you do here. The 3 responses. 5, 7. Any guesses on what the audience is going to do with this question? Here goes. All right, so we have 1 dissenter in the class.
It is a 1% improvement.
There we go. There we go. Obviously, the whole issue of what people are dealing with at an earlier age and what they see in the media, and my goodness, there's just a trauma going on. There are no child. I think if I remember right, they did pretty well. See if anyone changed their mind after this.
We did have a latecomer, so.
9 responses. Here we go. All right. So we gave up 1 dissenter in there. So, all right. Most of us kept to our
Probably went to the
guns.
store.
No difference in treating children, adolescents, and adults. Right? But Will's probably just playing with us back there, that's what. All right, but obviously we can see that most of us are in a disagreement with that statement. The only proven method is in a rehab facility. There's 100%. All right. So where else would we go then for treatment? If you don't agree with that statement, then what are some of your options, guys?
Stay home.
Okay.
Don't go
Okay.
anywhere.
Okay, but one could take it as family support and peer assistance and maybe working through some self-help materials.
And maybe a better word to use in that question would have been an inpatient rehabilitation
Mm.
facility versus getting services on an outpatient basis.
Hancock County embracing recovery-oriented system of care. ROSC. There's 100%. All right. All righty, if you will, join me in thanking our guests. Any parting questions of our guests?
We thank you very much for your attention. You're a good crowd.
Thank you very much. Appreciate it.